to visit Coorg, and have a nice Sunday. Thank you.
Thank you, Dr. Soumya. That was really precise and to the point. Now I'll request Dr. SAURABH MITTAL to present on ocular surface management for optimal outcome. Dr. SAURABH MITTAL is a pediatric as well as cornea fellow from Arvind, and he is practicing in Jalandhar with Thin Eye Hospital, and he's dealing in all type of anterior segment surgeries, maybe from transplants to pediatric ophthalmology to cataracts to LASIK. And Dr. SAURABH is going to throw light on a very important aspect which is usually neglected. Dr. SAURABH.
Good morning, everyone. Thank you, Vikram, for including me into this instruction course. So, this is a very important topic, dry eye in any field of ophthalmology. 80%, 75 to 80% of all of us do have some amount of dry eye. It can be mild, moderate, severe, or maybe worse than that. So what happens is, if a patient comes to you and if you ignore this particular finding and you do surgeries or whatever, or someone else does a surgery in your hospital, you have to finally face this problem. So I, being a dry eye specialist in my clinic and handling these patients, I frequently see so many patients, they are unsatisfied, they have good vision. Post-operative results in our hospital are excellent. We do have all type of equipment to make that possible. But this unsatisfactory levels are so high. See what happens once the patient enters into your clinic. This might happen 2 weeks, 3 weeks. Up to 2 weeks you can explain, but after that it's very difficult. So there is a patient. This patient comes to our clinic. Both eyes were operated. See, right eye, when we did the surgery, it was very comfortable. But when she underwent the other eye surgery, the main complaint was there is an explosive which has been fitted into my eye. Vision is good, but explosion because of the burning, of the irritation and whatever hard feeling they had. And she was like, every visit she used to complain. And finally she landed up with me. So what we did was, we took her to the set of examinations to see exactly if she has anything else, especially this mist thing, the dry eye. So we found that her tear film breakup time was in the right eye was less than normal. Shimmers was fine. Lipid layer analysis was done, which showed that the lipid layers were on a lower side, 41 in the right eye and 45 in the left eye. See, left eye was also not very good, but still there was no complaint from her on her side. When we everted the lids and looked for the Meibomian glands, we found that there was severe amount of MGD dysfunction. So this has to be seen before the surgery has to be done. At least we can explain to the patient beforehand, so that the level of satisfaction and the communication what we'll have with the patient helps us in giving her a better result. So why we miss this dry eye? See, patient is ignorant. Patient does not know anything when the patient lands up into our clinic. He just says vision is less, and rest everything he will forget or she will forget. And we also are most of the times ignorant about the dry eye disease. So patients, why we are ignorant? Because patient symptoms are variable, nothing to severe. Patient might not feel anything over a period of long time. And we also ignore it. If she is fine, then nothing else. Just go ahead with the surgery, because cataract is going to give you a lot of money. Identifying a dry eye probably might not do that, gives you that much of economical satisfaction. Now these symptoms, they vary from time with work and environment, and we do tend to miss some subtle signs when we are examining the patient. For in case we just ignore the pingecola and we just look into the pterygium. So we are ignoring some simple signs on the examination. Watering is a very common problem in dry eye. So patient will have reflex tearing. So patient will always say watering hai. So, and once the watering hai is, means that there is some amount of dry eye inside the eye. So, and there might be some other ocular diseases which are associated, and there might be no disease at all, especially in cases with refractive lens exchanges. So I call dry eyes to be an invisible disease. We have to look for it. If we find it, we can treat it. and we can make our patients comfortable. So what can we do to avoid this unhappy dry eye scenario? We should identify the disease, and this should be done preferably before the surgery, not after the surgery. And once this is identified, we should be counseling the patient that you have this particular problem and this has to be treated. Probably you can get it done before surgery or maybe after surgery, it's up to your choice. So, now what is dry eye? Dry eye is a universal phenomenon. It happens with everyone, almost everyone. Its prevalence is more, 10% with every decade, it increases. And the severity also increases with age. So more our age, the more the cataract, more the dry eye. So everything fits into a particular group of patients who are undergoing cataract surgery. And it's more common in female and in Asians. Here I've highlighted females especially because most of the complaints, they come from the females because they will be sitting idly at home, not working, and being a housewife, they will have some amount of irritation and they are more open to talk to the doctors than the males. There might be severe, the severity is also more with associated diseases like diabetes and autoimmune diseases. Ocular comorbidities like glaucoma medications, they tend to increase the dry eye. Surgical factors, what type of surgery we are doing? We are doing the way we are doing SICS, or we are doing phaco's, we are doing clear corneal, or we are doing scleral incisions. What is the amount of area inflammation before the surgery? Post-operative medications like steroids, they are going to aggravate our dry eye after the surgery, probably because of the particle matters getting clogged into the meibomian glands, or the steroid itself increasing the inflammation in the along the lid margins. Poor hygiene. We advise most of the patients not to splash water into the eyes, and they don't listen to the second part, that you can do clean your eyes after 2 weeks. They don't listen. They just follow this particular phenomena maybe throughout the life, that we are not supposed to touch our eyes once the lens is inside the eye. So they don't clean their lashes, and this increases the risk of infection, also increases the incidences of dry eye. So environmental factors like peak summers and harsh winters, they do have effect on dry eye. They do lead our eyes to become more dry. We have now plenty of activities which has decreased our incidences of blinking, like wrong reading, mobile work, working on computers. Along with that, if we are working in a low humid environment, like in air conditions, or with forced heating or forced cooling, that also leads to aggravation of dry eye. Now in this particular dry eye scenario, 80% of the cases are because of the disturbed lipid layer. And that is because of the decreased meibomian gland secretions. So this particular group of patients I am highlighting because they are all treatable patients. They are not the patients which we cannot manage easy. They are easy to treat, and they are the most genuine patients who can give you a very good result after surgery. So we know about what are the layers of the tear film: mucus, aqueous, or oil. In simple terms, we explain it to the patient like you have a sticky material, aqueous or water material, and the oil layer. So oil layer is the one which is disturbing you. Along with that, we should also be looking on the ocular surface and the lid margins for understanding the whole disease pattern. A very simple questionnaire is given to the patient because these type of patients, they used to come. So we have now incorporated all these things what we are going to highlight now into our daily practice. We try to identify dry eye before we advise any patient for undergoing any type of surgery, maybe it cataract or LASIK, or any other surgeries. We ask the patient for simple dryness, grittiness, scratchiness, irritation, burning, watering, eye fatigue. It takes hardly less than 30 seconds to inquire about the symptoms. And are these symptoms there from what duration is there of the symptoms? If the symptoms are frequent or if the symptoms are there from a long time, in that we make up a question. This questionnaire will give us a value that will be considered to go for a further investigation or not. If the value is more than 6, then we go for a further evaluation. So what are the further evaluations that we do? We do look for tear film breakup time, Schimmer's test. If you have the facilities for lipid layer thickness analysis, you can go for lipid layer thickness analysis also. You can do a corneal staining, and you have to do ocular and systemic examination to rule out other ocular comorbidities which can affect the dry eye. So if T-bud time is less than 10 seconds, that is considered to be abnormal. We should be looking for this functional capacity of the tear film. Schimmer's test we can do at all our clinics. Less than 5 is severe dry eye, more than 15 is normal, in between is borderline. Ocular staining, looking for epithelial defects or conjunctival staining. This indicates that probably there is a loss of goblet cell and the mucous layer is gone. So meibomian screen, we can press the meibomian glands with our finger. The pressure should be gentle enough. It should not be very hard. And if you see that there is a clear fluid coming out through the meibomian gland, this means it's fine. If the fluid is not clear, it is like a toothpaste material. This means that dry is going to be very severe. The secretions are very bad, and we have to treat these patients. We invert the lid and look for the meibomian glands. If you have the screening modules, you can do it with the help of them. And if you find that meibomian glands are shortened or they are absent, then we do have to tell the patient that you are going to have some irritation feelings after the surgery, which are going to get aggravated with the cataract surgery. So these are the, I'll take another 2 minutes. If the lipid layer analysis is done, you might find this rainbow type of pattern on that analysis. If the rainbow pattern is there, this means that there is a good layer of lipid, and the pattern is not there, this means the thickness is on the lower side. So disease counseling has to be done before the surgery. Patient should be made aware of the disease. They should be told that the treatment is required. They should be explained that surgery might aggravate the disease, and the different treatment modalities should be discussed with the patient. So before cataract surgery, a well-educated patient, aware of his disease, is the least unhappy patient. At the time of discharge, if we tell them, at least we can make him more comfortable by giving him some reasoning. But after 2 weeks or later, if we tell them that you have a dry eye, which we have not diagnosed earlier, he is going to be very unhappy with you, and he might not turn back, even with the treatment also. So treatment options, all we know is artificial tears, immunomodulators like Restasis, hot fermentation heat pads, punctal plugs, intense pulse light therapy, and LipiFlow. And there are so many which are coming in the pipeline. So disease management, if there is aqueous layer deficiency, we do go for artificial tears and punctal plugs. Lipid layer defects, we can go for oral doxycycline, hot fermentation, MDD expression with LipiFlow and IPL. Mucous layer defects, we go for cyclosporin, autologous serum, and anti-inflammatory agents like steroids. Meanwhile, our lady, which complained in the beginning, what we saw, we used artificial tears as a routine. We advised her to go for hot fermentation once a day. And we did gave her the intense pulse light therapy, one sitting with manual expression of the glands. And she was reasonably comfortable after 2 weeks. All that explosion has gone from her eyes. And after that, she never returned. This means that she was very comfortable. So I thank all of you for sparing your time this Sunday morning. And if you have any questions, you can ask, please.
Thank you. Thank you, Dr. SAURABH. SAURABH will take the questions at the end, right? That was really very precise. And one very important aspect which Dr. SAURABH has highlighted, that's regarding the more complaints in the females, especially because there are a lot of hormonal changes just around the perimenopausal and menopausal age, and that leads to more